Okay, so welcome to this next video in which we are discussing the drug treatment of rheumatoid arthritis. Okay, so at present we're discussing the pathogenesis of rheumatoid arthritis, and we've discussed so far that the circulating immune complexes which involve citrullinated fibrinogen bound to an anti-citrullinated fibrinogen antibody, these are somehow going to trigger an acute inflammatory response in the synovial joints, specifically synovial joints of the distal extremities such as the hand and the feet. Okay, and it's not well understood how these circulating immune complexes are going to lead to the acute inflammation here. Okay, but potentially what could happen is that you could get some other insult to the synovial joint, such as a mechanical insult or potentially a microbial insult, which triggers a little rise in vasopermeability. That allows the immune complex to leave the blood in those synovial joints and then binds to Fc gamma receptors on the surface of the sentinel cells, which then release interleukin-1, tumor necrosis factor alpha, histamine, which are going to trigger off the acute inflammatory response in full in the synovium. Okay, now what then is going to perpetuate the acute inflammatory response? Well, firstly, when you increase vasopermeability and allow the formation of an inflammatory exudate, one of the things that is going to move from the blood into the interstitial fluid of the synovium and also into the synovial fluid are more of these immune complexes. So you're going to bring in more immune complexes where you have citrullinated fibrinogen bound to this anti-citrullinated fibrinogen antibody. Okay, so I'll show this here. So here is the anti-citrullinated fibrinogen antibody bound to the citrullinated fibrinogen here. Okay, and this will then bind to Fc gamma receptors on the surface of the sentinel cells and therefore trigger a positive feedback of the acute inflammatory response. Moreover, you're also going to bring in this anti-citrullinated protein 4 antibody. So we're going to bring in antibodies from the blood which are directed against citrullinated proteins which are present in the synovium, basically. So previously these anti-citrullinated protein 4 antibodies, we're calling citrullinated protein 4 as our example of a citrullinated protein that's present in the synovium. Okay, previously the anti-citrullinated protein 4 antibodies could not gain access to the synovium and therefore could not gain access to citrullinated protein 4, so it didn't matter that they were circulating within the blood, but now they're going to come out in force into the synovium interstitial fluid. So here comes our antibody. Okay, and again now it's going to finally meet this autoantigen that's present within the synovium. Okay, so here is our citrullinated protein 4, but remember, of course, it's not called that. We don't know what protein this is that you're launching an adaptive immune response against. Okay, so that then leads to, again, the activation of Fc gamma Rs on the surface of the sentinel cells, and therefore the sentinel cells release more of their pro-inflammatory mediators, which keeps the inflammatory response going. Okay, positive feedback. And of course you're going to continue producing the anti-citrullinated fibrinogen antibodies and the anti-citrullinated protein 4 antibodies, so they're just going to come in and in and in. You're going to continue producing fibrinogen in the liver, so you're going to keep the circulating immune complex level high, and you're also going to continue potentially producing citrullinated protein 4 in the synovium, so these immune complexes will also continue forming. So these are going to continue this acute inflammatory response on and on and on, and it will become a chronic inflammatory response, chronic inflammation of these synovial membranes and therefore of the synovial joint. Okay, and it's this chronic inflammation which is rheumatoid arthritis then. Okay, now what we also need to discuss is that these immune complexes coming into the interstitial fluid of the synovium and also in the synovial fluid are also going to trigger positive feedback of the acute inflammatory response in other ways than just binding directly to the Fc gamma receptor. They're also going to activate the classical complement pathway. So let me discuss the classical complement pathway with you. Okay, so basically, the classical complement pathway is initiated when you have antibodies of the IgM or IgG type bound with that antigen. Okay, and it's going to activate proteins which are all in the blood in their inactive state and which are going to come into the interstitial fluid of the synovium and also into the synovial fluid, and then they're going to set up the classical complement pathway. They're going to activate basically as soon as they see these immune complexes. So one of the activating complement proteins is a protein complex known as C1. So let me show you the structure of C1, because it's not a single protein basically, it's many different proteins all stuck together. Okay, so let me draw a C1 protein complex. So C1 consists of 6 proteins which I'm drawing here, known as C1qs. Okay, and these are bound to 4 more proteins, which I'll show in a moment. So all 6 of these are what are known as C1qs. Okay, and they're then bound to 4 more proteins down here. So I'll divide this up into 4. And 2 of these proteins are what are known as C1rs. So here are 2 C1r proteins. And then the other 2 are C1s's. So this is C1s and this is C1s. So basically, the entire thing then is called C1. So all of this together, this is C1. So C1 consists of 6 C1qs, 2 C1rs, and 2 C1s's, like this. Okay, and now what's going to happen is this C1 protein complex here is going to bind to the Fc region of IgG immunoglobulins and also IgM immunoglobulins. But as I said, IgG is the main one that you've been producing, so certainly it will bind to these immune complexes. Okay, and when this C1 complex binds to the Fc regions of IgG and IgM antibodies that are involved in immune complexes, it will activate the C1 protein complex. And now what will start happening is this C1 protein complex will start breaking down 2 other complement proteins. Okay, so 2 more complement proteins which have come into the interstitial fluid out of the blood are C4 and C2. Okay, right, so this C1 complex, now that it's been activated, is going to break down C4 into a big fragment known as C4b here, okay, and then a little fragment known as C4a here. Okay, now C4a isn't going to do anything, but C4b is going to be very important. Now C2, okay, C2 is also going to be broken down by the C1 activated protein complex into a big fragment, and the naming system for C2 is much more complicated. It will also break down into a big fragment and a small fragment. Now I'm going to call the big fragment C2a and the small fragment C2b. However, over a decade ago now, someone decided that this was a bad naming system basically, and that all the other complement proteins fitted a nice pattern where the big fragment was called the B fragment and the small fragment was called the A fragment. But C2 broke this nice pattern. C2 had the big fragment called C2A and the small fragment called C2B. So over a decade ago now, someone decided to rename the fragments. Okay, so they decided to rename the big fragment of C2, C2B, and the small fragment C2A. And it kind of caught on, but now we're in limbo basically, where half of the world uses the old nomenclature, where you have the big fragment called C2A and the small fragment called C2B, and the other half of the world uses the new nomenclature, which is the big fragment is C2B and the small fragment is C2A. Now, my university is stubborn, so they taught me to call the big fragment C2A and the small fragment C2B, so I use that too. But you will see people using the new nomenclature where the big fragment is C2B and the small fragment is C2A. And if you Google classical complement cascade and get up, flow diagrams for it, okay, you will see if you take two, if you click on two different images, you'll probably find contradictions between the two. One will say that C2B is the important fragment, and one will say that C2A is the important fragment, and it looks like there's total contradiction, but in fact it's just two contradictory naming systems, basically. They both mean the same thing. Okay, right. So, whatever you want to call the big fragment of C2, that's the fragment that's going to be important. So we're going to call this C2A. Now, so what's happened is that once you've got these immune complexes present, they will activate C1, and C1 will start breaking down C4 and C2. And you'll get these two big fragments, C4b and C2a, and two little fragments, C4a and C2b, which we don't care about. Okay, now what's going to happen is, on the surface of glycoproteins that are potentially on the surface of cells, C4b is going to bind, basically. So you're going to bind C4b to glycoproteins that may well be on the surface of cells, or potentially they may well not be. They could be in the synovial fluid. Okay, but you're going to bind C4b to some sort of glycoprotein. Okay, and then you're going to bind C2a on top of that. Okay, like so. And this will form what's known as a C4b2a complex, and this orange thing here is a glycoprotein which they often dock onto. Okay, now this C4b-C2a complex is what's known as a C3 convertase, so it forms an active enzyme which can then break down another complement protein. So the next complement protein it's going to act on is C3. Okay, so you're going to break down C3 into two fragments. Okay, so a big fragment which is called C3b, and a little fragment which is called C3a. Okay, and there's no hideous dispute over what the big fragment should be named now, in the case of C3. Okay, now, C3a we'll come back to. This is going to be very, very important. But C3b is then going to bind to another complement protein. Okay, so I'll show this over here. It's going to bind to C5, like so. And once you've bound C3b to C5, this C4b-C2a complex can then act on the C3b-C5 complex and break it down into three pieces. It can break it down into C3b, it can break it down into C5b, the big fragment of C5, and also a little fragment of C5, which is C5a. Okay, right, so this reproduces the C3b, and that was only needed basically to allow you to actually work on the C5, and it also breaks down the C5 into C5b and C5a. Now, C5b will then go on and help form the membrane attack complex. However, we're interested in C3a and C5a, which will be being produced in the interstitial fluid of the synovial membrane and also in the synovial fluid of the synovial joint. Okay, now what are these two molecules going to do? Well, they are they are what are known as anaphylotoxins, okay, because of their involvement in anaphylactic shock. Okay, so anaphylotoxins. Right, and what they do is they act on mast cells. So C3a will act on the C3a receptor, C3a receptor on the surface of mast cells, and C5a will bind to the C5a receptor on the surface of mast cells, and both of these receptors will then activate the mast cell. So where have we got our mast cell here? Okay, so here is our mast cell, which remember is this type of sentinel cell. Okay, here's the nucleus of the mast cell, and on the surface of the mast cell you then have receptors for C3A, which is the C3A receptor here, and also a receptor for C5A, which is the C5A receptor here. And C3A is going to bind to the C3A receptor and activate it, and C5A will bind to the C5A receptor and activate it. And when these receptors are activated, it will lead to the activation of the mast cell, and the mast cell will then degranulate. It will release the histamine granules, which will release histamine into the interstitial fluid. So this is another way, basically, that having these immune complexes present in the interstitial fluid of the synovium and also in the synovial fluid is going to lead to the positive feedback of the acute inflammatory response. It's going to lead to the release of more pro-inflammatory mediators from the sentinel cells. Okay, right, so this is how the acute inflammatory response, the synovitis, is preserved, basically, how it's perpetuated, okay, by the continual production of these immune complexes which are being deposited into the synovial fluid and also into the interstitial fluid of the synovium. Okay, right, now let's discuss a few more things which are occurring in this synovitis, basically. So we've discussed one of the major things which is happening to perpetuate the synovitis, but let's actually discuss some of the things that are happening in it. Okay, so another thing that's going to happen, basically, when you produce an inflammatory exudate like this, is that you're going to bring in the components of the Calacrine-Kinin system. Okay, so next up we've got the Calacrine-Kinin system. Okay, so when you move proteins from the blood into the interstitial fluid, it's going to bring in the proteins that are involved in this Calacrine-Kinin system from the blood into the interstitial fluid, and when you do that, they're going to activate what's known as the Calacrine-Kinin cascade, or just as the Calacrine-Kinin system. Okay, so let's have a little picture. So, in the blood, there are 3 proteins that are involved in the Calacrine-Kinin system. Okay, and these are going to come out of the blood into the interstitial fluid, and they will activate, and the Calacrine-Kinin system will activate, and you'll end up producing bradykinin and calodin. But let's have a look at how this occurs. So what are these 3 proteins? Well, the first one is what's known as HMW, which stands for high molecular weight kininogen. Okay, so HMW kininogen, or high molecular weight kininogen. Okay, the next one is a molecule known as precalacrine. Okay, and precalacrine is so important that it also has an old name. Okay, so it's also named after the person who presumably discovered it, and it's also named Fletcher factor. Okay, so precalacrine, also called Fletcher factor, is another component that's going to be very important in the Calacrine-Kinin system. And then finally, there's also coagulation factor 12. Okay, which is obviously very important in the coagulation cascade, specifically the intrinsic coagulation cascade. And it's so important that it's also got another name, which is Hageman factor. But not only is it involved in the activation of the intrinsic coagulation cascade, it's also involved in the activation of the Calacrine-Kinin system. So all 3 of these proteins, high molecular weight kininogen, precalacrine, and factor 12, or Hageman factor, these are all produced by the liver and put into the blood. So let me colour them in. So here is factor 12 in red. Here is precalacrine, or Fletcher factor, in turquoise. And finally, in green here is high molecular weight kininogen. Okay, now what's going to happen is when you increase vascular permeability in the capillaries and post-capillary venules within the synovium, what's going to happen is that these proteins are going to all leave the blood and go into the interstitial fluid of the synovium, and also then into the synovial fluid. Now, when they get into the interstitial fluid of the synovium, they are going to come into contact with molecules that they were never ever allowed to see before. So, basically, these free proteins are made by the liver and deposited into the blood, and they circulate for ages in the blood, and are in an inactive form, and they're preserved in an inactive form. They don't activate the Calacrine Kinin system. They go around and around and around and around, and they have very boring lives. All they see is the other components of the blood and the apical surface of the endothelial cells. However, as soon as they leave the blood, because there's this acute inflammatory response occurring in the synovium, they go into the interstitial fluid, and in the interstitial fluid they see a molecule that they were never ever allowed to see before. Okay, and the key molecule that's going to trigger off the Calacrine Kinin system is collagen. Okay, so in the interstitial fluid you have collagen everywhere. It makes up the extracellular matrix, but the components of the blood were never exposed to it before. So when Hageman factor comes out of the blood, it will bind to collagen, okay, which was something it was never ever allowed to see before. And binding to collagen causes the activation of Hageman factor, okay, and it's now called factor 12A, or activated Hageman factor. Okay, now what happens is precalacrine follows it, but it doesn't bind to collagen. Instead, it's now going to be activated in turn by the activated Hageman factor. So once Hageman factor is bound to collagen, it gains catalytic activity, and it's now going to work on the precalacrine that has followed it out of the blood, and it's going to convert it into what's called calacrine, or you could call it activated Fletcher factor. Okay, but calacrine is a more common name for it. Okay, and now this calacrine is going to work on the high molecular weight kininogen, which has also followed it out of the blood. But it's not just going to work on high molecular weight kininogen, it's also going to work on another substrate, and this other substrate is low molecular weight kininogen, LMW kininogen. Okay, so high molecular weight kininogen was present in the blood, and it was produced in the liver, and it's going to come out of the blood when you've got this acute inflammatory response occurring, and therefore increase in vasopermeability, and great holes in the sides of the blood vessels which it can just move out of. But low molecular weight kininogen is produced by all of the cells in the peripheral tissue of your body. So normal cells are just chucking low molecular weight kininogen out into the interstitial fluid. So this stuff is just already present in the interstitial fluid, basically. Now, calacrine is going to work on both high molecular weight kininogen, which has come out of the blood and into the interstitial fluid of the synovium. And it's also going to work on the low molecular weight kininogen, which was already in the interstitial fluid of the synovium. Okay, now what's it going to convert them into? Well, it's going to convert high molecular weight kininogen into what's called bradykinin. I'm going to have to write it over here because I've just run out of space, basically. Okay, so it's going to convert high molecular weight kininogen into bradykinin, and it's going to convert low molecular weight kininogen, LMW kininogen, into caladin. Okay, now, for all extents and purposes actually not for all extents and purposes, but for our purposes, bradykinin and caladin are going to do pretty much exactly the same thing. And I should just say that caladin is also often referred to as lyse bradykinin, and the reason for that is that it's effectively the exact same molecule as bradykinin. It's just got an extra amino acid at the start, and that extra amino acid is lysine, so it's bradykinin with a lysine added onto it. So, because of the Calacrine-Kinin system, you're going to get bradykinin and calodin going up in the interstitial fluid of the synovium and also in the synovial fluid. Now, what do these trigger? Well, firstly, they're going to trigger type 1 activation of endothelial cells, and therefore, again, they're going to cause a positive feedback of the acute inflammatory response. And secondly, they're going to activate receptors on the surface of pain neurons. Okay, so they're going to activate receptors on the surface of these afferent pain neurons, which will therefore activate action potentials firing along these pain neurons. And these action potentials will be sent up to the brain, and that will trigger pain, basically, in the joint. It'll also trigger, similar things will trigger loss of function of the joint, so you'll lose the ability to actually use the joint. Okay, so this is going to lead to the pain that people suffering from rheumatoid arthritis feel. And it's not the only thing that's going to lead to the pain. There are many different things which are capable of activating pain neurons, but one of the things is this bradykinin and calodin that's being produced by the Calacrine-Kinin system. Okay, so we'll continue this discussion in the next video, where we'll discuss the coagulation cascades which will be initiated and how they're going to produce a fibrin cap where the intima of the synovium once was.